Good morning, everyone. This is basically an update from the infectious disease modeling group. I'm just going to give you basic highlights, not much detail. In light of that, meet the wonderful team. We have Jedra, Tari, Beth, Thomas, Claudio, Anne, Iselda, Fine, Lee, Ruth, and Andrea. Okay, my name is Anne, and I'm a research fellow with the infectious disease modeling group. My doctoral study was based on using mathematical models to study the impact of temperature and insecticide resistance. Basically, we looked at the impact of variation between indoor and outdoor temperature on the dynamics of malaria. One of the key findings of that study revealed that where mosquitoes rest after feeding and how long they rest there has a significant impact on the prevalence of malaria. And therefore, my research focus is based on using compartmental as well as agent-based models to study the dynamics of tropical infections, especially NTDs. All right, I would hand over to my colleague to introduce himself.
Yeah, thank you. My name is Ifeanyi. I'm also a research fellow in the group. Formerly, I did a PhD in University of Glasgow, where I looked at how to predict the onset of retinal hemorrhage. When we talk about busting of the vessels of the blood vessels in the eye. So we looked at how to model such behavior because of injury, that resultant injury in the brain, regarding the busting of the blood vessels in the eye. So I used relevant problems to solve the problem. So, but previously, I also did a PhD in Nigeria, where I also did mathematical modeling of infectious diseases. I was particularly looking at Lassa fever. So looked at ways of mitigating, look at different strategies you can use to mitigate Lassa fever in Nigeria. We also particularly looked at socioeconomic impact on Lassa fever. So we had some interesting results. But right now, I'm also interested in using computational and statistical models for some things or NTDs. I'm also looking at how we can give good guidelines to policymakers for different scenarios of different diseases. So that's basically what I do now. I will give you more updates of what I do in the group as we come. So I'll let her continue with our research.
All right. So this presentation is basically divided into the two broad parts of what our activities in the group is focused on. First, we try to use mathematical, statistical, and computational models to answer questions such as how does a disease spread? What are the main drivers of this spread? What controls can be employed, or how existing controls can be improved on? So I'll be going on to give some details about this. Basically, the infectious disease modeling group is an international network of disease modelers with a particular focus on a group of infections called neglected tropical diseases, such as schistosomiasis, onchocerciasis, Lassa fever, lymphatic filariasis, and soil-transmitted helminths. This group of infection impose a high burden of morbidity and mortality, and they are basically found in the tropical and subtropical regions of the world. Over the past 10 years, we've been able to come up with 243 research manuscripts, with over 18% of these making their way into policy documents. We hope that this continues. Now, basically, my work in the group is focused on schistosomiasis and soil-transmitted helminths, such as hookworm, roundworm, and whipworm. Of all the neglected tropical diseases, this group of infection impose the highest health and socioeconomic burden. And over the years, in many areas, treatment with praziquantel has not really yielded much impact. And so focus is being shifted to the use of more integrated control strategies, such as combining health education, treatment, snail control, environmental modification, as well as the WASH protocol. And this emphasis is laid much more in Africa that bears the highest burden of these infections. As a matter of fact, schistosomiasis in particular is being driven by human activity with water, such as swimming, open defecation, and the presence of the intermediate snail host. And so combining strategies would actually be a good way to bring down the prevalence of this infection. And so the first phase of my work in the group has been focused on studying the impact of snail reduction and treatment. From the results that are shown here, we can see that snail reduction has much significant impact in a high prevalence setting when compared to the medium and the low prevalence setting. Now, this might be due to the impact of the efficacy of the drug being used, actually acting or making the impact of the snail control not to be that visible. And of course, this result has also been recorded in some studies, especially the study that was carried out in the Zanzibar Island. Now, in addition to human activities, just like in the case of schistosomiasis, reports have also shown that climate change as well as climatic variables have significant impact on tropical infections like malaria and NTDs. Climate change can impact on vector competence, the range and the intensity of infections like lymphatic filariasis. And so the need to study this area more is what is being emphasized, and we think that in doing this, it would help us to adapt our present strategies in order to mitigate the effects of climate change.
All right. Some of the things we're also doing in the group is looking at potential impact of future tools like vaccination. So we are interested also in looking at what happens in the future, even in cases where we don't have vaccination at the moment, or vaccines at the moment. What happens if we do have in the future? So in light of that, the group recently published a paper in Nature Medicine, which in the summer. And in the paper, we are just trying to, first of all, estimate the burden of Lassa fever, especially in West Africa. So, because we know that Lassa fever is a disease that is predominant in that part of the world. So the paper tends to look at how do we estimate the burden of this disease and also look at different rollout of vaccines. How do we roll out vaccines in the future so that to mitigate Lassa fever? Lassa fever is, but let me give you a little overview of Lassa fever. Lassa fever is actually a hemorrhagic disease. It's a zoonotic disease that is hosted by a multivalent called mouse. So you can contact it by interacting with the mouse. For example, in local villages where it's hunting, people hunt for the mouse for it as food. You can also contact by if the mouse gets interacted with household materials, and you get in contact with it. There also can be person-to-person contact, and this is actually very dominant in probably hospitals where the medical practitioners tend to the people who are infected. So it is basically when you contact it, most times it is latent. You don't see the symptoms, but it can also lead to very severe cases of diseases. Sometimes people who suffer it for a very long time suffer permanent deafness. So they lose their hearing, can hear for some time because of the impact of that. So in this interesting study, which in collaboration with groups in the University of Liverpool and Liverpool School of Health, they were able to write up this interesting document. In the document, they were able to predict about 2.7 million Lassa virus infections annually, and they had these two types of vaccination rollouts. They have the preventive one. They want to roll out vaccines in the endemic districts. You had the WHO and say that the Lassa fever is endemic in this area, so roll out vaccines, and have the reactive vaccination. So the reactive vaccinations only had just about 10%, about 1/10, was able to avert about 1/10 of the economic challenge. But the most effective one was the vaccination was a population-wide preventive campaign that you roll out to those districts, and it was able to avert about 20.1 million in lost value and about $128 million in societal cost. So an interesting study. So right now, in view of that, in my study recently, after joining the group in this summer, I've been looking at trachoma. Trachoma is one of the infectious diseases, and it's caused by a bacteria called the Chlamydia trachomatis. It is you can contact by coming in contact with flies, and there are also possibility of repeated infection. And when there's repeated infection, how it does that the eyelids tend to interact with the eyeballs, and when they begin to interact, a lot of times the cornea tends to be scarred, and this can be very, 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 very painful. And there are other ways that has been recommended by WHO, by safe strategy, by surgery, the MDA, by antibiotic treatment, and facial cleanliness and environmental improvement. But these things we see that sometimes they tend to, even when this is done, like if you see this diagram, even when they have gone into a very lowest point, the prevalence has dropped about less than 5%. After some time, we see resurgence of this disease. So the idea is, what do we do if these things are not working? What do? We tend to look at other things we can do. So my study now is looking at vaccine. How do we different responses? How do we include vaccination into our strategy? So one of the things we are looking at here is looking at routine vaccination. So even though from our studies we'll see that it will really assist the reaching low prevalence goal and also prevent resurgence. But one problem we are seeing that it's going to be expensive to maintain, even because there are places where if you just roll out vaccines, there are places who are not really having this at that particular time. It's going to be an expensive problem. So, but we also have another called reactive vaccination. This will be in reaction to probably an outbreak. You just roll the vaccine in response to where the disease research, but there's also need to be sure that you have a sufficient coverage of vaccination. It's very important that you have sufficient coverage, because that will lead it not to also research in the future. So it's also challenging to start the campaign, but we also know that this trachoma can, like I said before, have repeated infection. Those have repeated infection, you have different age groups having infected over time. So, but actually has shown that it's predominant in about 0 to 9 years children. So our idea is to prioritize vaccinating children who are that age, and also vaccinating school children. That's going to help us. So what I'm doing, studying now, is to look at how we can prioritize this vaccination and target areas. So, so summarily, what we do in the group is that I try to provide national projections of future scenarios. We do projections of what is going to happen in the future. We try to see how we can project that using very interesting novel inferences. We integrate high performance pipeline in our system. So we process large data sets and which are different types of data. So when we do that, we tend to give policymakers ideas of what our projections are. So like donors, like the Bill and Melinda Gates, which fund most of our research, and even in governments, we give them policy directions of where to fund their research, how to fund the research, how to allocate resources. So this is basically what we do. Thank you for listening.